The problem with hyperglycemia and type 2 diabetes is it can be much more complicated to deal with than hypoglycemia. Often, hyperglycemia in hospitalised patients can be simply managed by temporarily increasing diabetes medications such as insulin, gliclazide or metformin. High glucose levels are common, especially in those with diabetes who are very unwell, and they can be managed safely. DKA is rare in people living with type 2, but they have a 1 in 500 risk of HHS as a result of mismanagement whilst in hospital. It's very tempting to give one-off doses of insulin without a proper assessment in response to high blood glucose levels, but this action can sometimes mask more serious clinical situations, and a decision made last thing at night without adequate consideration could lead to harm. Let's take a worst-case scenario. It's 11 p.m. and Mr. Jones is on the ward. He's in his 70s, has type 2 diabetes, is on metformin, and his glucose level is 28 millimoles per litre. Ketones aren't elevated. He's very unwell with an infection and drowsy. The duty doctor's called. 2 units of insulin are prescribed. Mr. Jones' glucose level comes down to 14. Over the next 24 hours, it rises back up again. He's still very drowsy and confused. The next night, a different duty doctor prescribes a similar dose. Next morning, Mr. Jones is diagnosed with sepsis requiring intensive care. To be safe, avoid one-off or stat doses of insulin without a proper assessment of the patient. Do be aware of hyperosmolar hyperglycemic state. It's a rare but life-threatening complication of type 2 diabetes, and these are the symptoms to look out for, which can be confirmed with a blood test. This is what should have happened to Mr. Jones. It's 11 p.m. and Mr. Jones is on the ward. His glucose level is 28. He's very unwell with an infection. Think about what made him ill. Sepsis, a cardiac event, and other infections will all produce adrenaline and cortisol, mobilising glucose into the blood and suppressing the effect of insulin, causing glucose levels to rise. Check for ketones. DKA is rare with type 2, but it happens. Ask the lab for blood tests. His HbA1c may help you work out if his high glucose levels are linked to the current crisis or not. Consider requesting urea and electrolytes, venous blood gases, plasma osmolality and other tests relative to the clinical situation. Those in a hyperosmolar state can register falsely low on a glucose monitor. And check for dehydration. Treat accordingly. Do you need to adjust any antibiotics? Is he on steroids, pushing up blood glucose levels? Could they be reduced? Does he need to stop his metformin and go onto a variable rate intravenous insulin infusion to manage the high glucose levels? In this case, yes, because he's unwell and not eating or drinking. Stat insulin doses are only appropriate if the patient is generally well. You can only make these decisions if you've undertaken a comprehensive review. Make sure you've gone to see the patient. Keep an eye out of nasogastric feeding. If the patient doesn't have enough insulin on board, it can push up blood glucose. If there's a blockage or feeding stops for more than 2 hours and insulin has been administered, it can go the other way and cause hypoglycemia. It can be difficult to keep blood glucose at target level in hospital. For those with diet and exercise controlled type 2 diabetes that's slipping out of control, there is a rescue treatment. If glucose levels stay above 12, you can give 40 milligrams of gliclazide with breakfast and again with the evening meal. Keep checking blood glucose levels before meals and bed. Talk to your diabetes team about discharge, and do consider renal function when prescribing gliclazide, as kidney injury can increase its effect. Number 1. Identify and treat the underlying cause of the high blood glucose levels. Is your patient unwell, drowsy or dehydrated? Consider HHS and follow guidance. If your patient is not unwell, not dehydrated, is any action necessary? Review medication. Consider altering regular doses to prevent it happening again. Consider use of variable rate intravenous insulin infusion in an unwell patient, and interact with the local diabetes team at the next available opportunity. Make sure you always undertake a proper review of the patient. Without doing this, you'll not be able to make an appropriate treatment plan. Assess their ability to self-manage and review their insulin use. Always remember that the symptoms might be the first presentation of someone with type 1 or type 2 diabetes. There's information and guidance for insulin doses, ketone management and intravenous insulin infusions available on the wards. If you're not sure, ask.